Hi everyone, welcome to CADIO's webinar series. Thanks so much for joining us today. We are so happy to have with us here in person today our colleague Dr. Rebecca Walwyn. Dr. Walwyn is an associate professor of clinical trials methodology. She's been working as a medical statistician in clinical trials for over 20 years, firstly at the Institute of Psychiatry in King's College London, and then at the University of Leeds. She is currently a UK National Institute of Health Research Advanced Fellow and Director of the Methodology or MRAE Division at the Leeds Institute for Clinical Trials Research. Dr. Walwyn, thank you so much for being here, and we're so excited for your webinar today.
Thank you very much for having me. I am probably going to sort of go through things in a bit of a whiz. And I will take it from people in the room if you want to slow down or quicken up and things. The plan is to talk about two newish types of complex intervention. They're all both fixed. The terminology is relatively in flux and might change over time, but at the moment I regard them as cascading and multi-level interventions, and they lend themselves to different trial designs, which I label therapist designs and cluster randomized designs. I'm going to talk about some new ideas as part of that, but also some current challenges and future directions that I'm going in associated with that. So to start by defining what I mean by the different types of complex intervention I'm going to focus on, I see the work that I'm doing as basically adding to the other part of this diagram, where there are other different types of optimization trial that aren't on the list at the moment. So I sort of see that the current fixed complex intervention as a flat intervention, where you have a series of intervention components, A to D here, and each of those are randomized to a set of patients, and then you're collecting an outcome on the patient level. In the ones that I'm thinking of, you would, in the multi-level ones particularly, you would have the same series of components. So you have the factorial treatment structure, but each of the components is randomized to a different level within a health or a social care system. So in this case, I've got 4 components, and then each of those are 4 sets of experimental units, and I'm randomizing to those experimental units, but I'm still assessing outcomes at the patient level.
Rebecca, I'm sorry to interrupt you. Apparently it's difficult to hear you. Just if you can just talk
I'll
a little.
talk as loud as I can manage.
Thank you.
Thank you very much. No, that's good to know. Okay, so that's multi-level interventions. The cascading interventions are easily confused with the multi-level ones, but because they also involve a multi-level data structure. But I call them cascading in that the example here is that you have training that's given to counsellors, and then the counsellors treat the patients. And in this case, you've got a case of multiple randomizations where the training is randomized to the counsellors, and then the counsellors are randomised to the patients. So in this case, your counsellors are both experimental units and treatments. And again, your outcome is measured at a patient level. This is particularly the case in surgery trials and in talking therapies such as psychotherapy. So what I'm imagining is that I've got a set of fixed interventions of different types that have different classes of factorial trial design. The multi-level interventions lend themselves to something that is known within the design of experiments world as a multi-stratum experimental design, and the cascading interventions lend themselves to be one of a type of multi-tiered experimental design, and I'll go into those in more detail as we go along. So I'm now going to talk specifically about the cascading interventions. That's the surgery, psychotherapy, occupational therapy, the person-delivered intervention type scenario. And I'm going to talk to start with about some work I did in my PhD about 15 years ago, where I in effect decided that the therapist should be regarded as a treatment component within psychotherapy, and that at an absolute minimum, if you're going to decompose psychotherapy into several components, the 2 components are the intervention and the therapist, and that they are potentially interacting. I looked at that as therefore saying that psychotherapy is inherently a factorial intervention or a multi-component intervention in that sort of sense, but that at the time, what people generally do is assess a package. So in this particular case, it would be counselling given by counsellors compared to advice given by GPs. And what you're doing in there is you're entirely confounding the intervention with a therapist characteristic. Having said that, people are generally interested in comparing counselling to advice. So you get a mismatch between what the trial is trying to do, which is comparing counselling to advice, with what it's designed to do, which is comparing counselling by counsellors to advice by GPs. There are a variety of different trial designs that you can use within this context, and I set out, as I say, about 15 years ago with the possibilities that we're going through. So I'm going to talk a bit about those as we go along now. The first one I call the cross-therapist design, using terminology from the design of experiments world, where each intervention is delivered by each therapist. And that's sort of a bit like the drug situation where the doctors are providing all the different drugs in the trial, and it's the norm in a surgical setting. It's less of a norm in a psychotherapy setting, but it is still commonly used. The alternative to that is that you might have an intervention such as a no intervention or a waitlist control or something of that sort that doesn't involve any therapist. And in that case, you've got a partially crossed therapist design because you've got crossing in 2 of the treatments and not in the 3rd. The design where most of the literature exists is the nested therapist design, where you've got different therapists delivering each of the interventions. And you can have a fully nested therapist design where all of them have a therapist involved, or you can have a partially nested therapist design where you've got a wait list or a control that involves no therapist in delivery. And those are the 4 main types of therapist design. And it can get complicated. So in real life, what generally happens is that people put these building blocks together to form individual designs of their own. So one of the landmark trials in the psychotherapy field is the Treatment for Depression Collaborative Research Programme trial that was done in the 1980s. And that involved 4 treatment, and the medical care was done by doctors, and therefore that was a crossed relationship, but the psychotherapy was done by different groups of therapists, and that was therefore a nested relationship. The PACE trial was my first example of a complex intervention trial, and in that case there was a co-intervention of medical care that was in all 4 arms, and there was a partially nested situation with the therapists under each of the 3 therapies, and then the doctors were providing the medical care across the board in a crossed design. This is quite common, so while I try and keep it simple, in practice it generally gets more complicated. That's the relationship between the interventions and the therapists. I also talked about the fact that there are different relationships between the therapists and the patients. So generally speaking, people assume that there is a single therapist per patient, but it is also quite common that there are multiple therapists per patient or multiple types of healthcare professional involved with each patient. And these lead to different types of design as well. I'm not focusing on the more complicated one of those today. I'm focusing on the hierarchical case where you've got 1 therapist per patient. Back 15 years ago, in my mind, you had these 3 things. You had the intervention, the therapist, and the patient. And most of the trials at the time were individually randomized, where you were randomizing the interventions to the patients, but the interventions were non-randomly assigned to the therapist, and the therapist was non-randomly assigned to the patient. You could have done a cluster randomized trial where you randomized the interventions to the therapists and everything else was non-random. But what I proposed at the time was that we thought about what I called a fully randomized trial design, where you randomize all of these different allocations. And I identified that as a multi-tiered design after Rosemary Bailey and Chris Bryan and their paper on multi-tiered experimental designs. Since then, I've done quite a bit of thinking, and in the course of the fellowship that I'm doing at the moment, what I'm deciding that we need to do now is to formally set up the designs of each of these therapist designs and all of the possibilities that you can have, and to work through, from a design of experiments point of view, what the expected analysis should be depending on the way you're randomising your trial. And that's the work that is currently ongoing at the moment. To be able to start that conversation with people from a design of experiments background, you sort of need to talk their language. And so what I have discovered is that these randomization diagrams, which is a diagram that Chris Bryan and Rosemary Bailey came up with in 2006, is a useful mechanism in that I find them relatively intuitive, so I can write one of these without thinking too hard. And then it can be turned into a Hasse diagram or something much more complicated, which then leads yourself to the analysis that's appropriate that comes after that. So in terms of cross-therapist designs, I think the ideal situation is an individually randomized factorial trial design where you have a number of interventions and a number of therapists, and you randomize the combination of intervention and therapist to patients, and that's what we've got at the top of that. So that's what that diagram tells you. So you're randomizing treatments to patients. Having said that, I think that if you can't do that, and there are situations, particularly potentially within surgery, where it isn't possible to randomize the surgeon to the patient, that the best you can do next to that is to stratify the randomization of interventions to patients by the therapist or the surgeon. In the nested case, I think the ideal situation is the composed multi-tiered design where you have multiple randomizations of interventions to therapists and then therapists to patients. Having said that, if you can't do that, I think that the next best things that you could do are a cluster randomized trial design where you're randomizing the interventions to the therapists, but the patients are nested within those therapists, or randomize the therapists to the patients where the therapists are nested within the interventions. And there are examples of all of these designs out there in the literature, but they generally don't appreciate that they're doing anything odd. So they will call themselves parallel group designs, even though these clearly are not. This leads me to the fact that when you're dealing with a nested design, and to repeat, the nested design is where you have different therapists delivering each of the interventions. There are two different types of nested design. You've got one nested design where you have a single sample of therapists, and they can be randomized to either deliver treatment A or treatment B. And actually, there are other types where you can't do that because you couldn't possibly randomize the therapist to the intervention because, for instance, it involves 12 years worth of training to become that therapist or whatever it happens to be. And so there is a sort of general design that I'm thinking about at the moment where you don't have the possibility of doing a multi-tier design, which assumes one population of therapists. But if you have multiple populations of therapists, you end up with a different design. And this is the diagram that goes with that design. And it gets more complicated. So the ones that look a bit like this, you end up with a very similar situation, but special cases of that general design, where you're talking about partially nested designs or partially cross designs. And each of these lends themselves to a different type of experimental design. The ones that look particularly odd, these ones here, are designs that are new to the experimental design community as well. So I'm working through them one at a time with examples, and there will be papers coming out around. So I've highlighted at the bottom the two papers that I've contributed to. There is a long literature about these designs in the psychotherapy field, going back at least 50 years, possibly more. It is relatively recent that it's hit the medical statistics community. So Chris Roberts was particularly involved in that, and his first paper was in 1999. And there have been other papers that have been since. It has, as a field, started to explode. There are a lot of people using it. They tend to call them different things so that there's a language issue. They call them individually randomized group treatment trials, where to me it isn't group treatment. Group treatment is something different. So there are bodies of literature around this, and I can point people to that if they're interested. I'm now going to take you to the multi-level interventions and tell you a bit about where I've got to with those. The specific example I have with this is one of my audit and feedback trials. So the idea is that you do an audit of blood transfusion practice in hospitals, and that's your baseline data. You use the data from the audit to form the feedback that is given to the hospitals, and then you do another audit after that, and that becomes your outcome data. The feedback is your treatment in this particular case. So we had 3 potential feedback components. There was an audit report, there was support given to transfusion practitioners, and then there was a slideshow or an information session given to regional transfusion committees. We did this trial twice, so the same design was repeated in a surgical audit and a haematology audit, one after the next. The outcome was a binary outcome of whether blood transfusions were unnecessary or not at the patient level. So the intervention design looks a bit like this. So in effect, what's actually happening is that the slideshows are happening at the regional level. The support is being given to transfusion practitioners, who are then cascading that down to hospitals and clinicians. The audit reports are given to the hospitals, and then at the end of it, you're hoping that you're going to have an impact on patient outcome. So the simplest design that you could go for in this case would be to have 2 different types of feedback that you randomise to transfusion practitioners within regions, and then collect data on audit cases within transfusion practitioners. And that is a straightforward 2-arm parallel group cluster randomised trial design. We made it a little bit more complicated than this when we did the trial ourselves, in that we separated out the effect of the support from the effect of the reports. So we ended up with a 2x2 factorial design. We again decided to randomise those treatments, those 4 treatments, to the practitioners within the regions and collect data on the patients. And that was a 2x2 factorial cluster randomised trial design. What I probably would have preferred to do, but we didn't do because it wasn't usual and there wasn't an established literature around it, was to allocate the support to the transfusion practitioner and the reports to the hospitals. This would have given me far greater power to look at the effect of the reports at the hospital level, because I have many more hospitals than I have transfusion practitioners by a sample of about 2. So this would be a split plot type trial design, where you have 2 different treatment components randomised to 2 different sets of experimental units that are nested with one another. In an ideal world, I might also have worried about the slideshows that were happening at the regional level, because the idea of the slideshows was to try and improve the way that people were talking together and share practice across the region. And if that was a source of potential contamination, which made us worry about it. But actually, if I'd have just regarded it as part of the design, then I would have ended up with a split plot trial design, where I would have randomised the 3 components to 3 different levels. I said before that Affinity used repeated trials over time, and we were interested in the fact that across time that healthcare system might learn, and that there were potentially different topics involved in each of the trials, and that we were actually interested in whether you can have a general effect across audit topic or whether you have a specific effect of particular feedback mechanisms for particular topics. So in an ideal world, I would have done 12 trials instead of 2, and I would have randomised my audit topics to the trial or to the month within which I did the trial, and then I would have had my feedback given to the transfusion practitioners. And the 130 transfusion practitioners would have been in every single trial. So you've got a cross relationship between the months and the transfusion practitioners. And that makes it a 2x2 crisscross trial design, which is a special case or a particular type of split block trial design. And the way I tend to visualize these, because I find these more anti-intuitive than I find the split block type trial designs, is that I draw myself a little table like this, and I can imagine that every grayed out combination is possible in this particular case. And I've got 5 audit cases within each month, within each practitioner. And then the months are going to audit topics and the practitioners are going to different types of feedback. But there are, as there are with most things, a lot of different possibilities, and that within the general idea of a split block type design, there are different possibilities as well. And so This is an example of one that might work if you needed to do the trial in a sort of batch-wise way. So when I've done trials of care homes, what we've generally done is do our intervening within a batch of the care homes and then to go and do it to another batch, and we keep going through that. And this is probably, again, easier to think about in terms of a diagram. But what you're doing, in effect, is repeating the design within a block. And in this case, it's within a region, so that you go across the different regions. And you may, for the purposes of practicality, want to do this sort of design. So the point to say really is that that the world is your oyster. There are lots and lots of different things that you could do, and each of these has a literature associated with it. So to talk about the current challenges and where I'm going with this, the first thing is that the language of all of this is very much based in agriculture and within industry, and you can read papers on design of experiment and it not make particular sense in a health and social care context because the language doesn't make sense. And so I'm starting to think about, once I've got the concepts in my head, what would be more intuitive language than the ones that I've done. Split plot means absolutely nothing.
Even, I was just thinking that plot stuff, that comes right out of there.
And you don't, and the equivalent would be a split patient design, but we don't do those. So actually, I think that there needs to be a language, and I'm working through those. In terms of the other thing, I think that because the literature has existed outside of medicine, some of the things that are particular to a medical setting, which is the messier side of the experiment, are things that I think deserve time in themselves. So there are situations where you can't randomise everything that you want to randomise, but it would be nice to know what's the next best thing. So those I'm calling partially randomised designs. There are situations where you can't force orthogonality, where you don't have the same number of hospitals in the same number of transfusion practitioners, and that forcing that orthogonality is not a good idea for your power. But
Can I just interrupt you and say, just for the audience, that when you say non-orthogonal designs, you're talking about varying numbers of participants across experimental conditions, right?
I am, yes. They're not synonymous, but they are sufficiently synonymous that you can think of it in that way. And then really longitudinal designs, because I've never done a trial where we've had just one outcome time point, and the designs don't generally get thought about in terms of more than that. And so from my point of view, I'd like to extend the literature to these sorts of areas. In terms of future directions, when I was being interviewed for my fellowship, I was told by one of the panel members that this has already been done before. And I looked at him in horror, thinking, I'm not aware of this having been done before, but I thought I ought to find out. So as a result of that, I've been doing some systematic methodological reviews, trying to find out whether people are doing these designs without necessarily realising it. They're certainly not doing it and realising it, but it may well be the case that there are examples of those out there. So within the different types, we're looking at those. Because there is no obvious language, this is difficult. You have to get people telling you how the randomisation is working in their particular case. And I have found a good, sizable handful of people doing these designs without necessarily appreciating that they're doing something different. They're nice examples. It's been a useful exercise. Those papers will be coming out soon. The other papers are more sort of taking people through the literature that exists in these areas. There's more literature on multi-stratum designs because those go back to Yates in the 1930s, and there's a big literature on those. So a lot of that will be taking those forwards. The multi-tiered experimental design literature is much newer, and therefore I'm doing a lot more developing of the work around those. So there are therefore more papers coming out, and I wanted to stop there.
There's a question in the chat that we could maybe begin with. And broadly, this is about contamination in these different designs, specifically referring to this affinity design, but also just in general. Can you expand a little on your thinking about the chances of contamination and what you're thinking about in terms of minimizing it?
Okay.
So there was a particular concern with affinity because there is always the possibility of contamination. What we generally did in that particular case was record what we could of what was happening, and then potentially take it into account. My feeling is that the trial design should be done based on what you want to happen, and that anything that doesn't happen around that should be an analysis issue rather than necessarily a design issue. So I would be all in favour of analysis approaches to taking into account of contamination. What it basically does is add interactions to your situation that you wouldn't necessarily want in a straightforward design. So I think the question I suppose I have is, if I had stratified the randomisation by region, then I could potentially come up with an orthogonal contrast to look at the effect of each of my intervention components independently of the effect of the slideshows, which I think is the next best thing.
Great, thank you. Any other questions we want to kick off with from those of us in the room?
When I look at these designs, they're so interesting, but can you talk a little bit about the added complication of kind of layering a factorial experiment onto this? I mean, it's a really a nice framework that you have here. And I love the diagrams, but I'm imagining, kind of they're thinking about layering say a 32 condition factorial experiment onto this, and just the challenges. Obviously, I mean, I'm all in favor of doing that, but the challenges that would be associated with that.
The first challenge is that most randomisation systems aren't set up to having hundreds of treatments being randomised to your patients. So as a result of that, you need a randomisation system that can do that.
Yes.
Within your sort of situation.
Yeah.
I think there are issues. You also have potential consent issues because your therapists become participants in your trial in the same way as the patients are. So should you put them through an informed consent process in the same way as you might your patients? I think you possibly should, but then I don't think that should be different irrespective of how the trial's randomised. I think that should be because the therapists are a participant in the trial.
Yeah, wouldn't that be the case even if it was just a regular 2-arm RCT though?
Yeah, I think so, but I don't think people are thinking like that at the moment.
Ah.
I think they're thinking of their therapists as research staff as opposed to as participants of their trial.
Okay.
Which is a reasonable way of thinking about it, because 20 years ago most of them were research staff as opposed to embedded within clinical services.
Yeah. Gosh, it seems like as soon as you introduce random assignment, they're not research staff. Yeah.
Yeah, and you're collecting data on them. So collecting the data was probably the first thing that dawned on me. Potentially when you have multiple care providers or therapists involved with a particular patient, mapping out exactly what the data structure looks like is probably one of the first things that you have to get your head around.
There's another question in the chat that is relevant here. Can you clarify, when you say therapist, are you generally referring to the type of provider, more like a component, or actual individual humans? I think I'm struggling with the design implications if it is the latter, because people leave, change efforts, etc.
I'm talking about the actual person themselves being a level of the factor of therapists, but that they may have characteristics such as be more experienced or less experienced. They might be professionals versus paraprofessionals. Various things. They may be male or they may be female. And you may be interested in the therapist characteristic as well as the individual themselves. And yes, there are definitely practical considerations around staff turnover, missing data and that sort of thing. Yes.
Yeah, missing data that is then that much more important, right? Because you're losing a whole factor of your...
You are. Having said that, the literature that's happened over the last 20 years or so has assumed that you're doing an individually randomised trial, but that you need to account for this non-randomised treatment factor in the primary analysis anyway. So I don't think the randomisation necessarily makes it any worse. The difficulty becomes with the ideal design would be to have multiple therapists within each clinic, so that you've got the ability to randomise to therapists within clinics. So you're dealing with designs potentially with quite large numbers of therapists is an ideal, whereas when this wasn't seen as such a big thing, it was quite usual to have anywhere between 1 and 6 therapists involved in a trial. then now it's becoming the norm for them to be in the late 10s. So you're talking about a relatively big exercise, and I think that it's probably a design for a definitive trial or a confirmatory trial, just as much as it would be an optimization trial, because I don't think you can separate out the effect of the therapy from the effect of the therapist without incorporating it in this way.
And that would also potentially add more ethical considerations, right? Because now if you're treating therapist as the participant, like for ethical considerations, you have to make an argument to withhold certain interventions for the patients. Now you're also potentially withholding training for the therapist to do different types of interventions. And that's like essentially adding another argument or reasons for the design.
Which potentially might mean that the cross design, where all of the therapists would be trained in all of the therapies, would be better, and I haven't thought of that as a possibility. Yeah, I mean, from a statistical point of view, the cross design is better than the nested design because you haven't confounded the therapist with the therapist by treatment interaction. So, and you've therefore got more power to deal with it in the cross design. The problem is whether you can get a therapist to learn lots of different therapies.
Well, that's where the contamination comes in. I think you have a real potential for contamination there. In my experience, which is limited, it's often hard for the people delivering interventions, if they're tasked with delivering different components or different versions of an intervention, it can be hard for them to do what they see as withholding a treatment that someone potentially could benefit from. And of course, we know that if there's equipoise, there's not a body of evidence that suggests that treatment would be helpful to the person. It could even be harmful, you just don't know. And that's the whole point of doing an experiment. But I think it's hard when you're on the ground and you perceive a need. It's hard. It's hard to say, well, I don't want to cause contamination in this sort of very abstract experiment when I've got someone sitting in front of me that I could potentially help.
And I think that's the reason why there's been an assumption, which is very much an assumption, that the nested design is the more common design within the psychotherapy field. I'm not sure that it actually is, mainly because over the last 10 years or so, there have been a lot of trials that have looked at, say, a very common therapy and then add on an extra component or not to it. And therefore you've got those therapists that are able to do all of the different packages that are being evaluated. So actually the cross design is also being used, to my surprise, actually, as much as it is.
Can I ask another question? So you talked about this work in connection with the figure of MOST that has the optimization phase and then the and others. I'm curious whether you've thought much about optimization objectives for designs like these, like especially these ones with therapists that we're talking about. What is it that someone would be trying to decide about the intervention when we're factoring in these considerations about therapists?
So it's a slightly strange factorial design because your therapist is a random factor and your therapy or your intervention is a fixed factor. Whereas in most factorial designs, they're both fixed effects. And so you've got, and that's relatively unusual across the board, and not just in our literature. And as a result of that, what you're trying to do is to work out that you've got a reasonable amount of variation depending on which therapist you got, so that it's not wildly different what you get from one therapist to the next as you're going along, alongside the optimal, the average treatment effect being the best you can make it for that particular intervention. So I think it may be that you want to trade off the fact that if you can get a moderately worse average outcome against much less variability of that outcome across different therapists, that would be better than having much more variability but potentially a greater average.
Interesting.
That is interesting. I never thought of variability like that being an outcome, but I guess it's kind of related to the equity work, isn't it?
Right, yeah.
What about other considerations that might come up in decision making, like cost, or the amount of time that it takes to deliver an intervention? Would you expect any considerations like that to come up in decision making?
I think they would double because you'd have them at the therapist level as well as at the patient level. So I don't see why you couldn't use a similar approach at both levels, and they may be different considerations at both levels, I would have thought.
Well, that's another direction to take, our decision-making approach.
Yeah, all sorts of new dimensions for that approach.
Yeah.
We're going to get into a 4-dimensional space. I don't think that our Shiny is really equipped for that kind of
No,
thinking.
not yet.
Inside Jillian's brain, she's like,
Rebecca, I wonder if I could ask you to just change the topic a little bit and talk a bit about intervention optimization in the UK. Just in general, do you feel like it's taking off? What do you see as the barriers to adoption, that sort of thing?
I think it is taking off, but it's pretty slow. I think there are pockets of people who are very interested. Leeds is an example of a pocket of people who are very interested. I don't think it's the norm yet. The guidance that we all follow is the MRC Complex Interventions Guidance, and its most recent update included the possibility of refinement as a stage that would happen. And I sort of see refinement and optimization as synonymous.
Okay.
So that could happen either at the sort of early stage or it could happen at a late stage. You either do it in an exploratory sort of setting or you do it in a confirmatory sort of setting. I don't think that matters to us. I think the barrier potentially is within people feeling familiar or there being a literature to support the designs that they're using. So I think that using the most literature, I think people can argue their case. They'll have a harder time of it because the board members potentially won't be familiar with it. But I think as more of them go through, I think the board members will be.
By board members, you're talking about what?
Funding panels.
Reviewers,
Yeah.
of grant proposals.
Absolutely. I think that the one that we've talked about is the idea that you shouldn't use a factorial design if there's any possibility of interaction, but I think that is a discussion that isn't insurmountable. I think you just need to explain yourself to a greater degree.
Yeah. Rebecca's referring, for the audience, Rebecca's referring to opinions some people have that we don't agree with, that you should not use a factorial, that you should use a factorial experiment only when you can assume that there are no interactions, which
is by definition not the case in a complex intervention.
Yeah, absolutely.
So yeah, I think really it's time has come. I think that people will start to do them. I haven't found anybody who doesn't see the point when you should explain it. It's lack of familiarity, I think, is the issue.
Yes.
Looks like Chuck has his hand up. Nice to see you, Chuck.
Hi, thanks for a great discussion. I figured I'd give a shot at a question. So I'm thinking about sort of the translational pipeline from efficacy, effectiveness, and then on into sort of routine practice. And once sort of patients are selecting their therapists and there's a good fit or not a good fit, how does that sort of impact what you might have discovered when things are sort of more designed, sort of how can you learn about sort of what to suggest for individuals and sort of finding the right therapist for them?
The thing that actually really I was really quite taken with is that if you randomize the patient to the therapist, you are in effect randomizing the patient to the therapist's gender or all the various different characteristics of that therapist. And so you can answer causal questions about the best therapist fit for the particular patient population that you've got in your head. And to me, that opens up all sorts of possibilities because there is there's clearly a desire to do that, but most of the work that's being done at the moment is observational as opposed to experimental. And so there are, as a result, the sort of limitations associated with that. You have your patient characteristics, you have the possibility for moderators. It gets very complicated very quickly. But actually, you could do that more sensibly, I think, if you were to do this purposefully design this as an experiment. I think a lot of the trial designs at the moment are happening without being done purposefully, and I think that's the downside to it, is that you might end up having most of the patients treated by one or two therapists and then 20 or so other therapists treating one or two patients. and you're limited in what you can do in that situation. But I don't think people appreciate that that's a problem.
Thank you.
Any other questions here in the room or on Zoom? If anybody else wants to raise a hand and give a question or put one in the chat. In the meantime, I'll just, oh, yes. Kyle asks, what suggestions do you have about reporting, writing up trials to explain the nuances of randomization, therapist effects, etc.?
Ooh, good question, Kyle.
A tough one too.
The best I can do on that is I suppose it'll come out of the methodological reviews that I'm doing, in that I will discover whether I can work out what people have done on the basis of what they've told me. People tell you more than I thought they would, so it's not always the case that they'll tell you whether the therapists are doing more than one intervention or not, and I think they should. You should know what the design is, whether it's a cross design, an nested design, etc. It would be nice if you were planning the number of therapists as part of your sample size calculation, but I don't think that people do particularly. So you should know the number of therapists you're planning at the beginning and roughly what their caseload is going to be. I think that you should know about how you've selected the therapists from a population of therapists. So there's the sort of generalizability, external validity side of it. I think you should be very clear about what you've randomized to what, and I'm proposing the idea that these randomization diagrams go into trial protocols to explain how the randomization is done, because the more realistic the trial it is, the more complicated it gets, and there are so many different possibilities that having a name for each of them that's accepted, I think, is unlikely. So I think it's best to just describe what you've done in the most explicit way and then come up with much more general titles for what the trial design is. So a therapist design would be fine, or a cluster randomized trial instead of a split plot or split block, because they are, in effect, are versions of cluster randomized trials. They're just different types. So I think that I don't think we're at the right point yet to come up with guidance about how to report things, but I think being as clear as you are about everything that you're doing, I think, is the advice at the moment. There is a consult diagram, consult statement for non-pharmacological interventions, but I don't think this covers, it assumes that you're doing individual randomization of interventions to patients, so there's more to do.
You must have a requirement in the UK that you have to register clinical trials in advance like we do here.
We do, yes.
Yeah, and so some of these designs must be a real challenge to put in the register.
I think that people just don't tell you the details. Yeah. I mean, that's one of the nice things about fitting this into a sort of factorial framework, because I think that you have to if you do it in that sense. Whereas, generally speaking, everything's boiled down to the two-arm parallel group trial design that is the intervention to the patient.
Another question in the chat from Angela. I imagine you'd have to show that you could feasibly randomize patients to therapists and that patients would accept that and be retained on top of being willing to be randomized to a treatment as well. In practice, this seems really difficult to me, but have you seen this happen successfully in a specific context?
If I will be quoting a series of people who have done this. I've found, I think, about 30 or 40 examples of people who have done this in trials out there. And the sorts of issues that they talk about are therapist availability, in that people are getting being allocated to a therapist who happens to be available at that point to take on a patient. Otherwise, what you're doing is extending the waiting time for that patient to see a therapist by having more of them available at any one time. So I think that's probably one of the biggest practical constraints that people do. And so there is a sort of randomizing to the subset that are available at that point, as opposed to all of the therapists in the trial. So I think that the therapist turnover and the therapist availability are the two biggies, really, in terms of the practicalities that need to be thought through. But it's certainly possible people are doing it.
But I think adding on that, it also depends on the settings, because I was thinking, like, so for example, if I went to NYU Student Counseling Center, they would ask me if I prefer a female or a male counselor. In that setting, I think if it's kind of common practice to ask for preferences, then it might be more difficult to say let's randomize, and you don't know which of the therapists you're going to be randomized to. But if it's more of a standalone intervention that you're still testing, then people might be more willing to be like treating it as a research project versus a routine care.
Yes.
I think that's also similar if you're doing it more in a pragmatic trial setting.
Yes.
Then patient probably will have more power in terms of deciding on the preferences of providers.
Yes, I would agree entirely with that. I think that you have more control at an earlier stage in the experimentation than you do at the later stages of it. And so I would probably want to learn as much as I can while I have that control. And then possibly it goes under my set of partially randomized designs. The thing that people aren't necessarily aware of at the moment is that there are analysis implications to not randomizing. And what I want to be able to do is to set out, well, okay, if you can't randomize your patient to your therapist in this particular trial, what are the implications for the analysis plan?
It just seems like that's a great opportunity for non-ignorable dropout, because I could imagine someone who has a strong preference agreeing to be in the study, but then thinking, I really prefer a female therapist. If I get assigned to one, fine, and if I don't, I'll just drop out of the study, go get routine care.
Yeah, I think there's a lot to do with the sort of relationship between the patient and the therapist that is part of the reason for dropout.
Yeah. I get asked a lot how to incorporate patient choice into optimization trials. And it's hard, you know, it's hard to know what to do about that. I've often thought it would be interesting to, and actually this must have been done somewhere, the head-to-head comparison of patient choice versus no choice. Or maybe if a component has two levels, level A, level B, and then you get to choose between level A and B. That would be interesting.
I think there are lots of potential complications that you could add into the situation.
Yeah, that would be complicated.
What I've decided to do is to start with the mathematically simpler stuff.
Yeah.
And work through the ideal case first, and then potentially expand it and make it more usable in practice afterwards.
Yeah, you have to.
Yeah.
And Donna comments in the chat, and if you could randomize to choice, no choice, that would be ideal.
Mm-hmm.
How about another question from Liz? What are your thoughts on how provider types may be different? For example, have you thought more broadly about how primary care providers may provide care to larger caseloads of people versus therapists who may have a more specialized population and smaller caseloads? How would that impact design considerations?
I had a trial of a particular type of psychotherapy for children. It involves the child psychotherapist having loads and loads and loads of experience. And as a result, there are usually only one or two in a location. Whereas more generally, there are what we call IAPT services, improving access to psychological therapy services, where you'll have 50 odd therapists within a service. Generally speaking, what I think it does is that you've got to take the level of the service into account when you're making the design. So the papers that I'm writing at the moment views the service as a non-randomizable treatment component of the therapist as well as of the patient. So the therapists generally are nested within services, although in the land of remote therapy that we're going into at the moment, that's not necessarily the case, but the designs get more complicated. The other sort of element of complication that I've taken into account is that the time, you don't get the same therapy from a therapist if you see them when you're their second case, and if you see them when you're their 100th case, because they've built up a body of experience.
Yeah.
So taking into account learning curves is the other thing that I've built into these designs, so that you can include those complications within there as well.
Very nuanced analyses you could do, I imagine.
I suppose we're getting down to the end here.
Yeah.
So I'll say thank you again, Rebecca, for your very interesting presentation and this very thought-provoking conversation about all of this. This is so interesting to think about. And thank you for being here in person all the way from the UK with us at CADIO today.
Thank you very much.
And thank you everybody for attending. We'll see you again soon. you.